Welcome back to Long COVID Doctor, an educational series for those of you with long COVID. I'm Dr. Tim Robinson, formerly a family doctor, a GP for 30 years, but now working in Long COVID Services for 5 years. I post on all the usual podcast channels as well as on YouTube. I hope you find these postings helpful. And if you do, obviously click subscribe. I want to get as many followers as possible, not for my own personal gain, but because I want to get these messages out to as many of you long COVID sufferers as possible, especially as now, certainly here in the UK, a lot of long COVID clinics and services are being withdrawn. And so patients are being left just like to fend for themselves and they're high and dry. And so this is a trusted resource for you patients with long COVID. And hopefully you can learn a lot to help with your symptoms and help with the recovery from your long COVID. So, as I say, click subscribe and also share to anyone you know who has long COVID. My usual disclaimer, and that is, basically any treatments or strategies, any advice that you hear from me in these podcasts and postings, please don't consider until you have talked to your own family doctor, your own GP about the treatments that I mentioned. So, anyway, here we go. This update is on the chest pain that patients with long COVID are experiencing. And it's quite a common symptom. Certainly one of my top 10 symptoms that I'm seeing in patients in the long COVID clinics and services that I work in. So, chest pain associated with long COVID, an update. So, first and foremost, what are our patients telling us? So basically, they are presenting with chest pains of many different descriptions. So, some patients are saying that they've got this whole chest type of chest pain. So both sides, bilateral. Or they're saying, actually, it's only on one side, unilateral. So different locations. The nature of the chest pain is different in different patients. Some people describe a knife-like pain, sharpness. Other patients describe a sort of a dull, bruised ache. Very different, sharp or dull. Some patients identify it as one particular spot, so along the sternum or in between the ribs or down there along the costal margin, or just over the whole area, a whole large area. So either pinpoint or covering a large surface area. Some people describe the pain as sort of in the soft part or the hard part. So in the soft part, so the muscles, soft tissues, or just over the bone or a joint. So hard part, soft part. Again, the actual onset of it. Some people say that the onset of their pain is very gradual, Other people say it's very sudden, with movement or at rest. Some people say that the pain is only in one area, one-sided, both sides, but going nowhere else. Other people say that it's extending elsewhere, up to the neck, down the arm, round to the neck, through to the back. The pains, again, could be very variable, could be there all the time, or only when they're moving, the patients are moving. And there may be associated symptoms. Maybe there's breathlessness, or maybe there's cough, other symptoms with their chest pain, i.e. not just in isolation. Hearing the description and teasing out what the patient is actually experiencing and all the features about it is so important, because it actually leads us to the diagnosis. And if we've got a diagnosis, we know what we're dealing with. And if we know what we're dealing with, we probably know how to deal with it. So let's think about the different causes, because like I've said, that detailed history has led to the suspicion as to what we're dealing with and their underlying causes. The underlying causes, of which unfortunately there are lots. Okay, and in a way I've whittled it down to 8 causes. Okay, so hold on. So the first cause, angina. So heart muscle pain. Second cause, and I'll talk about these all in greater detail as I go through and explain them. So first is angina, that heart muscle pain. Secondly is pericarditis, inflammation of the heart, the sac in which the heart sits. The third cause is pulmonary embolism, so a blood clot on the lung. Fourth cause is pleurisy associated with underlying infection in the lung, underlying pneumonia, pleurisy. Fifth cause is a condition called Tietze's syndrome. So costochondritis, inflammation of one of the joints. There are joints all the way down the sternum. The ribs join the sternum. One of those joints might be inflamed. Tietze's syndrome, costochondritis. Intercostal, another cause, that's the sixth cause, intercostal muscle inflammation, be it a strain or a tear, intercostal muscle. The muscles between these are the intercostal spaces between the costals, otherwise known as the ribs. So intercostal spaces, the muscles there, intercostal pain. And then finally, the 8th cause is pleuritis. So, seventh cause, costal margin. So inflammation of the margin at the base of the rib cage, the costal margin. These are sort of a string of cartilages that link them all together. Okay, link all the base of the ribs together. And then finally, the 8th cause, pleuritis, the COVID grip. So inflammation of the lining of the lung. We've had inflammation of the lining of the heart, pericarditis. This is inflammation of the lining of the lung, pleuritis. Okay, so 8 causes for chest pain. Already you've sort of realized lots of different underlying tissues, organs, conditions that leading to all these different pains. So there we go. The question is, how are we going to distinguish one from another? How are we going to differentiate between the different types of chest pain? Well, it all comes down to the story, the history. So let's talk about them each in succession. So first of all, it was angina, wasn't it? So angina pain is classically a dull ache, a crushing sensation, a heavy weight, a band around the chest, doctor. It feels like I've got a belt around my chest. These are all the descriptions our patients with angina give to us. It is a chest pain classically with exertion. It can happen at rest. That's what we call unstable angina. But more classically, it is chest pain that comes on with exertion, with walking, with going upstairs, with exertion. That classic angina pain can extend up to the neck or down the left arm into the jaw. I've had patients where it's actually gone through into the back. Okay, but the classic one is down the left arm. What is angina? Basically, as I've said, it is heart muscle pain. And what's the underlying cause? The underlying cause is narrowing of the arteries, the coronary arteries, that serve the heart muscle with oxygenated blood. If the heart is working hard, it needs more oxygen. If the arteries, the coronary arteries, are narrowed, you're not going to get enough oxygen going through. So then that leads to heart pain because of buildup of lactic acid, because of anaerobic respiration. So angina is obviously to do with furring up the arteries. But what we've found during COVID, and hence now long COVID, that there was an increase in incidence of angina because of the underlying COVID problem of inflammation throughout the body, particularly the blood vessels, endothelialitis, causing those narrowed areas to become inflamed and disrupted, and fatty plaques then separating and blocking off or further narrowing the coronary arteries. So this is what we've seen in long COVID, acute COVID, and then that leads to narrowing of the coronary arteries, that leads to less oxygen going to the heart muscle, which leads to angina pain. It's a worry, of course, because, a plaque, an atheromatous plaque in the coronary artery that's become unstable can then rupture, and then that can lead to a heart attack. Not good news. So that is your classic angina chest pain, right? To add, insult to injury, then there's another type of angina. We call this microvascular angina. And microvascular. So what is microvascular angina? Well, it's in the title, isn't it? Microvascular mini blood vessels. If you like, coronary artery disease, narrowing of the coronary artery, is macrovascular angina. This is microvascular angina. It's due to what we call dysfunction of the microscopic blood vessels in the heart muscle itself. These are the microscopic, as in less than half a centimeter, less than half a millimeter, minuscule, tiny, half a millimeter blood vessels that are part of that whole, what we call a vascular tree, coming from the coronary arteries that go and feed all the muscles, the heart muscles. They don't work so well in someone who's suffering from the ill effects of COVID, now has long COVID, because of the inflammation that occurs with COVID, has inflamed those mini blood vessels, but also the formation of microthrombi, those little blood clots that can occur in those micro blood vessels. Plus also, you're probably all familiar with the term dysfunctional autonomic nervous system, dysautonomia. So with dysautonomia, then the control of those blood vessels is lost. So when you need to open up your blood vessels, the autonomic nervous system, when you want to exert yourself, go for a run, what have you, those blood vessels should be opened, and they'll be opened by the autonomic nervous system. If you've got dysautonomia, dysfunction of the autonomic nervous system, they're not going to open. So you're not responding to the exercise demands, the demands that exercise is placed on you when you want to do some exertion. What do you do about it? Basically, angina, either macrovascular, coronary angina, or microvascular. Well, basically, you need to see a cardiologist, and probably pretty quickly. You may even need referral to the rapid access chest pain clinic, because angina, like I said, can lead to a heart attack. Okay, we want to rule out a heart attack. We want to rule out narrowing of the coronary arteries that potentially could lead to a heart attack. And, cardiologists do that very well. Angiograms and CAs, CT scan for the coronary arteries, very good at diagnosing this. And, and if you do have a narrowed artery, and that's the cause of your angina, you have angina because of the coronary arteries being narrowed, you need to have a stent put into your coronary artery. You need medication, you need drugs to help open up those arteries. But also likewise, microvascular angina, even if, so microvascular, the problem isn't in the coronary artery, the problem is in the microvascular supply. Then, you need medication for that to try and open up those mini blood vessels. So that's that central dull ache, compression, heavy weight, band around my chest, doctor type of chest pain, angina, chest pain. The other form of central chest pain, pericarditis. So inflammation of the sac in which the heart sits. Okay. This is in the category of central chest pain because it is central. It can be left-sided because that's where the heart is, more on the left, off to the left. Okay, so that type of central chest pain, or central plus left-sided chest pain, you're thinking already, to do with heart. Interestingly enough, that the pericarditis pain is more of a sharp discomfort, knife-like, prickly feeling, sharpness. And interestingly enough, it's worse when lying flat. Okay, it's better with leaning forward. So patients classically say, I've got this sharp pain right there, etc. And weirdly, it's better when I sit forward. And so obviously, our medical knowledge and GP's awareness of that type of chest pain will get them thinking, I bet that's pericarditis. And what's the cause of that? Well, basically, it's inflammation. I've said it's inflammation of the sac, of the heart sac, the pericardium. Okay, that's all part and parcel of, again, another example of inflammation from COVID, another area, another tissue, another sort of surface lining that has become inflamed. Okay, inflammation. What do you do about it? Well, obviously, off to the cardiologist. Yes, in the old days, in general practice, we used to be a bit more gung-ho and we used to treat it, because we felt we could. Actually, I feel more comfortable now referring on to the cardiologist for this. I think most GPs would say the same. So that's central chest pain dealt with. Okay, i.e. both sides, central and both sides. What about one-sided chest pain? Well, I've broken this down to, if you like, one-sided chest pain because of the lung, troubles happening in the lung, and one-sided chest pain happening in the musculoskeletal system. So let's focus on the lung. What can go wrong in the lung that's going to give you one-sided chest pain? Well, there are two things. Okay, so the first is a pulmonary embolism. So it's a blood clot in the lung tissues. And classically, it is one-sided chest pain. It is a sudden onset. It's like a knife going into your chest, accompanied with breathlessness, and worse, with a deep breath in. So not only shorter breath, but actually, if you try and take a deep breath in, it stops you taking that deep breath in. And what's the cause? Well, I've said it already. It's a blood clot on the lung. Again, this is serious. Off to accident emergency department, ED. You need to be treated. You need treatment to have a medication that's going to disperse that blood clot. So there's an amazing group of drugs which have been around probably 10, 15 years now. So direct acting oral anticoagulants. We used to use warfarin, rat poison, which has actually fallen out of the way along the wayside now because you had to monitor it really closely, and it was very easy to over anticoagulate people, and then people started bleeding here, there, and everywhere. So we don't use that any longer. We've got DOACs, thank goodness. So a drug like dabigatran or Pixaman, excellent drugs for this one-sided chest pain, which is sharp and due to a blood clot on the lung. The other one-sided chest pain of lung origin is pleurisy with an underlying infection, classically a pneumonia. Okay, and so the doctor, will elicit the accompanying symptoms, which are usually a cough, productive of mucky, horrible, purulent sputum, as well as breathlessness. So an underlying chest infection, which, if you like, if there's a segment of your lung which is infected, then that infection goes up to the edge of the lung, and then that inflames the lining of the lung, the pleura the pleura is the lining of the lung, so inflames that part of the pleura. Again, it's uncomfortable to take a deep breath in, and when we listen through the stethoscope, we hear a sort of a crunching sensation and a sort of rub, a pleural rub. And we hear that both in pulmonary embolism, but also in pleurisy due to an underlying infection, pneumonia. So again, that's serious. You want to get it treated. You probably need intravenous antibiotics. Certainly need intravenous antibiotics, so it's off to the hospital. So that's your second cause for one-sided chest pain originating from the lungs. Okay, we now move on to one-sided chest pain originating from the musculoskeletal, the skeleton, i.e. the rib cage. Now, so there are three of these. Okay, so first of all is this condition called Tietze's syndrome, costochondritis, inflammation of the costochondral joint. So the ribs come around they take their origin from around either side of the thoracic vertebrae, and they come around and then attach to the sternum bone, the bone, the rib cage sternum bone here in the center. Each of them, therefore, have a joint between the rib and the sternum. Unfortunately, one of those joints can become inflamed at one particular time. I've never seen someone with two joints inflamed at the same time. Quite a common diagnosis in general practice, but it's where the rib joins the sternum. And interestingly enough, so patients will say, I've got this pain in the chest, it's on one side, and it's just here. And often the patients identify the joint that is inflamed, which is really handy, really helpful, because actually, even before I've got my stethoscope out, I've put my hand on the chest, I've made the diagnosis. I proceed with the examination to confirm the diagnosis. So if I work my way down one side of the sternum, if they're saying it's on the right side, I work my way down the right, and then I come to third, fourth, fifth, whatever, joint, and it's really excruciating painful, then I've got the diagnosis, costochondritis, costochondral joint pain. And direct pressure, and I then press on that pain, and that they don't like that. A patient does not like that. That's really painful. What do you do about it? Well, it's inflammation of a joint. Joint inflammation, you need an anti-inflammatory. It's common sense, really. So some ibuprofen, 400 milligrams, 3 times a day. That'll help. And it'll take time for it to quieten down. It's probably happened because of a strain or forceful coughing. And so it'll take time for that inflammation to dampen down with the help of the anti-inflammatory. Remember what we say always, anti-inflammatories, make sure that you ask the patient whether they've got indigestion, heartburn, whether they've had a ulcer in the stomach in the past, etc., because they have therefore a tendency for excessive acid. So anti-inflammatories make that worse. They can cause ulcers. So in that case, then you'd be wanting to treat with paracetamol instead. But certainly ibuprofen, not on an empty stomach. Make sure you have it with, a slice of bread or, with the food, not on an empty stomach, just to be absolutely sure you're not going to irritate the stomach lining. So that's the first of the 3 musculoskeletal causes of one-sided chest pain. What's the next one? The next one is inflammation of the intercostal muscle. I explained this, what this costal, I think is probably Latin for rib. I don't know, I think so, probably. So intercostal, so in between each rib, you've got the intercostal space. In intercostal space, you have the intercostal muscle. Intercostal muscles, like any muscles, can be strained, stretched. And with straining and stretching of a muscle, you have inflammation. So the pain is felt not on the bone itself, on the rib itself, it's felt in between the ribs, in the soft part, the muscle between them. Again, the patient will say, it hurts really hurts here where I press between these ribs. And already you've got the diagnosis before I get my finger on the painful part in order to confirm in my mind the diagnosis. Classically, the patient finds it uncomfortable to take a deep breath. So worse with direct pressure, but also with moving and also sort of twisting and tilting left and right. So these movements sort of bring out the pain. Again, helpful to me when I'm trying to make the diagnosis. Again, it's a muscular thing. It's inflammation of soft tissues, muscles. So therefore, you need an anti-inflammatory. So good old ibuprofen comes into its own yet again, with all the usual provisos. And then on to the third type of one-sided chest pain due to musculoskeletal problem. Well, this is pain of the costal margin. What's the costal margin? Costal margin is the base of the lung, base of the rib cage. So the rib cage, at the base of the rib cage, you have these cartilages which can be inflamed or out of alignment because they're sort of concertina dovetailed together down here, the sort of 8th, 9th and 10th ribs, and they all are sort of glued together with cartilage. They can become disrupted. I've had it myself. I landed on the costal margin and put it out, and really painful, one-sided sharp pain. Again, and anti-inflammatories is what you need. Manipulation, I actually manipulated my costal margin back into alignment. You can do that, or you could you go to an osteopath or a chiropractor to actually put it into place. So there we are. That's the 7th cause. Now on to the 8th cause. Okay, this is what we call pleuritis, and this is inflammation of the pleura. Sort of the pleura are the linings, the envelope. It's a double layer that the lungs are surrounded by. This double membrane. It's a sac that contains the lungs. And patients describe a sort of general discomfort of their whole chest. So it's usually bilateral, both sides, and it's large areas. And they describe various things. They describe as sort of an awareness. I'm aware of my lungs, doctor. I've not been aware of my lungs before. And it's a sort of constant feeling. And the lungs feel sort of stiff and chest rib cage feels stiff. It's like being gripped. And some patients describe this as the COVID grip. And it's worse with that awareness of that tightness is worse with a deep breath. And it makes you aware of your breathing. I've never been aware of my breathing before, doctor, they say. So an awareness of your breathing. And it is, again, like pericarditis, inflammation of the heart sac. This is inflammation of the lung sac, okay, because of the COVID process, inflammation. What's the treatment? Well, it is soft tissue, so theoretically an anti-inflammatory will be able to address this. So ibuprofen, yet again. However, what we found through experience is that a drug called colchicine is even better at dealing with this inflammation. Colchicine's been around for donkey's years. I mean, it's an ancient anti-inflammatory drug. It's derived from the crocus flower, or the autumn crocus. The ancient Greeks used it for joint swelling. The ancient Greeks, like that's 2,500, 3,000, 2,500 to 3,000 years old. Culpeper, the apothecary, included in his list of plants that have medicinal properties. These days, and throughout my professional career, we used it for gout, for acute onset gout, for those patients who couldn't tolerate anti-inflammatory tablets. So indomethacin was what we use mostly. It's probably mostly being superseded by ibuprofen. But, if you can't take anti-inflammatories, which is quite common, you can't take indomethacin or ibuprofen, then we would prescribe colchicine. Cardiologists have been using this in pericarditis, inflammation of the heart sac. And during acute COVID, when there was quite a few patients with pericarditis, the patients were also telling their doctors that actually my pericarditis is better. Also, my lung discomfort is better. So we learned through what our patients told us. Colchicine, as I say, it's been around for donkey's years. It's well, we're all familiar with it. It has very few side effects, but it does have a significant side effect called known as diarrhea. This is really the only common side effect, and we're all on the lookout for this when we prescribe it. There are rarer ones, something weird and muscle inflammation condition called rhabdomyolysis. There's, your white blood cells can drop down with it, or you can have raised liver function test. So these are all things that we've got to be looking out for, but they're all rare. The commonest is, like I said, diarrhea. Because of those rare conditions, we ought to do kidney function test, liver function test before starting it, and then 4 weeks afterwards, and then on an annual basis. The usual dose is 500 micrograms twice a day. And start low, go slow. You might need 3 times a day, you might need 4 times a day to dampen down that inflammation. But 500 milligrams, in my experience, twice a day was usually enough. You might need it for 3 months whilst that inflammation of the lung lining takes to settle down. But you may need to continue it for 6 months, 9 months. There's no reason for not continuing it. It's safe. And interestingly enough, anecdotally, our patients who are treated with colchicine for their long COVID pleuritis, their COVID grip, do report back to us and say, actually, do you know, my fatigue and my brain fog, particularly my brain fog, is better since having colchicine. A win-win. So very, very good news for those patients. So what should we do? So anyone with chest pain in long COVID needs to visit their doctor. Why? Because we've got to get a diagnosis. I've said this so many times before. The doctor will take the history and, all the symptoms, the nature of the symptoms, and get the sort of the fine detail, the nature of the pain and how it affects you and where it affects you, etc., etc. What brings you relief, what makes it worse, etc., etc. Then the examination, obviously a cardiovascular. It's a chest thing, so you want the cardiovascular examination. You want the respiratory system examination, probably oxygen saturation levels done with pulse oximetry on your finger. You want investigations, obviously, guided by what you found on the history and the examination. So D-dimer, if you suspect there's a blood clot. Obviously chest x-ray, if there's a suspected underlying pneumonia. ECG, if you think it's a cardiac thing. 1 minute sit to stand to check for desaturation of oxygen. Doctor, of course, any doctor whose patient comes in and says, I've got chest pain, automatically is thinking of all the red flags. Is this a heart attack? Is this angina? Is this pneumonia? Is this a pulmonary embolism? Tuning in. Because, it's a matter of referring appropriately and timely for any of those worrying cardiac conditions, worrying respiratory conditions, for scans, etc. So it's off to the hospital. Yes. So there we are. Chest pain in long COVID, the update, and the 8 underlying causes, and how to distinguish between those different causes and differentiate, and hence to get the diagnosis, hence to get the right treatment, hence to bring relief. What can I say? But, those treatments, each of those treatments have their own specific, each of those 8 different conditions have their own treatments. And as I said, there may be referrals. And, I talked about the underlying COVID processes that have contributed to that long COVID chest pain. So, the appropriate treatment will hopefully deal with your chest pain and take it away. But remember, in the overall overview of, treating long COVID, we've got to take the overview picture and how to manage it. We want to look at the holistic view, and that is to look at the whole person. And, those long COVID chest pain may well be coming with fatigue. So we want to be addressing the fatigue with the planning, the pacing, and the prioritizing. We want to be, feeding, the optimal health measures of, sensible diet and sleep and dealing with stress, and reconditioning with yoga and dealing with stress with mindfulness. So let's look at it in the whole overview picture. And, and if we take all that into consideration, hopefully with time, those specific symptoms, your chest pain symptoms, will settle, as well as your long COVID will settle. But it takes time. Natural healing takes time. So there we are. That is my update on chest pain in long COVID. I hope you found it helpful. And as I said at the start, this is an educational series for you long COVID sufferers. And my objective is to get it out there to as many of you long COVID sufferers as possible. So share this with anyone you know who has long COVID. Click subscribe, to get as many, as much coverage and awareness as possible, because I want to help as many people as possible. Remember, as I said, anything I've mentioned on the treatments, etc., basically ask your doctor first, just before you run off and take your own healthcare into your own hands. So there we are. So in the meantime, I wish you well. I wish you well in your long COVID recovery, and, like I said, I hope you find these postings helpful. So, all the very best to you. Cheerio. Bye-bye.